Morning once again. In the next few minutes, I'll be giving an overview of the lenticule procedures. Okay. So, as I said, the refractive surgery has evolved rapidly. The lenticule procedures have evolved in a span of a decade. It has come to the mainstream of refractive surgery procedures. So, let me talk about the journey of refractive surgery. We started with PRK. PRK, it was a bladeless, flapless procedure. Then we moved on to blade LASIK with blade, mechanical microkeratome. Then we got femtosecond LASIK. With this, we used to make a flap. Then to move on to complete the circle, we are back to bladeless, flapless, lenticule-based procedures, which is termed under CLEX. What is CLEX? CLEX, it's a keratolenticule refractive lenticule extraction procedures. It is termed under CLEX in the year 2023. All these procedures started with the introduction of femtosecond laser. Professor Sekanto and Blum introduced flex with femtosecond laser. They made the flap and the lenticule. Later improvised to small incision lenticule extraction procedure in the year 2007. It is recognized as a birth of SMILE, and Dr. Rupal Shah performed the first SMILE procedure in India. This is the geometry of a lenticule. It is a minimally invasive procedure. We use the femtosecond laser to create the lenticule according to the refractive error of the patient, and the lenticule is manually separated and it is extracted through an incision of 2 to 4 millimeter. We have various platforms available all over the available from various companies. The Elita Silk, then comes the SMILE. Visomax has 500, and now the latest Visomax 800 is we can do SMILE Pro with that. Then Clear from Zima and SmartSight from Schwint. Let us go through the various parameters of each machine. Overall, the so energy wavelength is almost same as around 1040, but the main difference is in the laser pulse repetition rate, which is the laser pulse repetition rate is maximum with the Zima, and then comes Elita. And all this while we were trying to reduce the amount of energy per pulse from the earlier days. So we have come up to 50 to 70 nanojoules with Zima. And next is with the ATOS. Then different patient interface platforms are available. It is curved with Visomax 500, 800 as well as ATOS, and it is flat with Zimmer and Elita. And the major problems in the initial days of lenticule extractions were the cyclotorsion compensation and the centration issues. Now we have rectified that. Other than the Visomax 500, we have impulse cyclotorsion compensation and post-docking centration system in all the machines. And there is a lenticule side cut with Visomax 500, 800 as well as Elita. It is not there with ATOS and Zima. And the shape of the lenticule is planar convex in all the machines except Elita. It is biconvex lenticule. The main advantages of lenticule procedures, other than the other techniques like PRK, LASIK, there is no flap, so we are not cutting the corneal nerves, only the 2 to 3 millimeter incision on the superior part. Very few nerves are transected, so less induced dryness, and no flap, so there is no flap related complications as well. And we are not disturbing the anterior stroma as well as the Bowman's membrane in lenticule procedure, so better preservation of corneal biomechanical strength and less induced dryness, and less induced IOP rise intraoperatively, and less higher order aberrations, induced aberrations. And the environmental factors like humidity, temperature are not affected with lenticule creation like with excimer laser ablation. There are certain limitations too. The learning curve is a little longer because we have to identify the lenticule, separate the lenticule. We do it manually. It takes a little more time compared to the other procedures. And initial days, we can have incomplete lenticule extraction. And the hyperopic correction is, as of now, it is not possible, but it is almost on the way. We may get it in few months or by next year. And pure astigmatism also is not possible. And the cost, especially the initial investment and the consumables, are little on the higher side. What are the major changes since 2007? The lasers have become more faster and the incision has become smaller, and we got dedicated instruments. We have learned more about the instruments, and the cyclotorsion compensation and the post-docking compensation is improved, and the energy management, that is the most important. We got better idea about how to optimize the energy. That is very important for the results, post-operative results and intraoperative lenticule management. And retreatment options are available now with Visumax. Circle software is available, and the hyperopic treatment we can expect within few months. And now the lenticule, whatever is lenticule implantation procedures are done for keratoconus and sometimes for hyperopic treatment also. Let me share a few of my learning experience. I started with silk. We have the ELITA machine. Dr. Rushad was kind enough to be there during my early days of surgery. And energy optimization is the key for postoperative visual recovery, fast visual recovery. And the instrument, as and when the numbers increases, we can modify our instruments according to our convenience and the procedure. To conclude, lenticule extraction has matured to a highly predictable, minimally invasive, a flapless refractive surgery option. It is no longer a future, it is the present of refractive surgery, and it is going to stay here. Thank you.